We have a few folks already called in. For those of you who have already called in, if you could take a moment to complete the poll on the right-hand side of your screen. You might need to expand the window if you just see the chat function, but there should be a polling function. And there's just 3 short questions that we ask you to take a moment to answer. Giovanna from the California Healthcare Foundation, I think we have a couple more folks called in. And we're just requesting that you take a moment to answer the polling questions on the right-hand side of your screen. You might need to expand the window that says polling. Started. Welcome, everyone. This is Giovanna Giuliani from the California Healthcare Foundation. And thank you so much for joining today's phone call. If you could take a moment to answer the polling questions on the right-hand side of the screen, we'd appreciate it. We'll probably close the poll in about 2 or 3 minutes. So just a few housekeeping, logistical things that I want to go through. We always get questions about whether or not the session will be recorded and whether or not the slides will be available. And we do post both the slides and the recording within about a week of the webinar. And what we'll do is, for those of you who have registered for the webinar, even if you were not able to attend, so if you had colleagues that registered that couldn't attend, we include those folks when we send out the slides and recording. If you have questions, if you have logistical questions, you can chat the host using the chat function on the right-hand side. If you have a question for the speaker, please use the chat all function so that everyone can see your question, and we will be moderating that chat session as we go through the webinar and giving questions to the speakers. So as you know, if you registered for today's event, we are talking about looking at variation in elective surgery rates and how one community in Humboldt County took the California Healthcare Foundation all over the map data and analyzed it and engaged their stakeholders, the community as well as providers, to have a conversation about it and figure out next steps. And it's really very exciting work. And I want to introduce today's speakers and give a brief bio about them. Martin Love is the CEO of Humboldt Del Norte IPA, Foundation for Medical Care, and the North Coast Health Information Network. Previous to these positions, he held a number of positions at General Hospital in Eureka, including CEO. As lead or administrative lead, he has been involved in 5 projects with the Foundation, most recently working with Dave O'Neill, who is a past CEO of Public Hospital. And Martin has a BA in zoology from UCLA and an MBA from Humboldt State University. And Betsy Stapleton is the lead consumer representative for Humboldt's Aligning Forces for Quality initiative. She has over 30 years of experience in healthcare. She graduated from Stanford University's Primary Care Associate Program in 1979 after having worked at nursing at small hospitals in remote Northern California. She was then a family nurse practitioner until 2003, when she could no longer continue in clinical practice due to a serious medical condition. And this really opened the door for Betsy to wider involvement in quality improvement work. From 2004 to 2006, she attended the California Healthcare Foundation's Healthcare Leadership Fellowship, and she's been instrumental in bringing the Stanford model, the Kate Lorig model for chronic disease self-management, to her community and engaging consumers to participate at the highest per capita rate of any county in California. She's been part of local and national efforts to design performance reporting materials that are comprehensive and functional for consumers. And for those of you who are also on CHDF's distribution list, I think you might know that we recently released our All Over the Map, the new version of the All Over the Map data, and a wonderful story about what you're going to hear about today that we asked a writer. And there's an interactive module on our website. So when I send out the email with the slides and the link to the recording, I will also include the link to the new All Over the Map data and to this story about Humboldt's work so that you have access to that. Hold on. Okay, so now I am going to pass the ball to Martin to get started.
So this is Betsy, and I'm actually going to talk about our first slide here. And it's an introduction to the community that we'll be telling you about, which is Humboldt County. and we're in far northern California. There's one other county between us and the Oregon border, and we have 130,000 residents, most of whom are in three closely proximal towns. And we're very rural, we're poor, and we have quite high morbidity and mortality. We have physicians, 240 of them, about 65 are primary care, and we have many NPs and PAs, most of whom are in primary care. We don't quite know the exact number. There's 26 primary care practices, and we are in the rural, small practice model. 5 docs is a big practice. Many are solo physicians with maybe a nurse practitioner, PA, or 2. There's 3 hospitals, 2 of whom are in one system, and the other is an independent, privately held hospital. And each hospital is located in one of the 3 towns in our community, which are Fortuna, Eureka, and Arcata.
So this is Martin. And for us, the project started with the California Healthcare Foundation publishing a report by a Stanford economist, Lawrence Baker, detailing surgical rates for 13 preference-sensitive procedures across California. The report had rates for every hospital referral region and hospital service area in the state, and it neatly covered everybody in Humboldt. So while probably not necessary for this group, I'll define preference-sensitive as procedures and the underlying conditions for which a number of different treatments are valid. And the choice of treatment depends on the preference of the patient and or the clinician. So when we read this report, we were really impressed. It used data from OSHPD for the years 2005 through 2009, and that amount of data allowed for statistically robust inferences and comparisons. It was adjusted for standard demographic variables so communities could be compared, and it was also adjusted for the baseline rate of myocardial infarction in each of the communities for the cardiac procedures. The rates were based on where the patient lived, not where they had surgery. But we were able to show that for most of the procedures were performed somewhere in Humboldt County. And this is one of the reasons it needed to be a community project. Patients might live in one town but get their surgery in another town in Humboldt. So we looked at these rates and we were really surprised about how many were high. And we define high as 150% or over the state average. And while those rates weren't necessarily wrong, we were certainly concerned. Of the 13 procedures, 6 were high in Humboldt, and some were as much as 2.5% the state average. And for most, they were high in all 3 of our hospital service areas. So we talked about this a lot, and after a lot of consideration, we decided that we were most interested in CABG, cholecystectomy, hysterectomy, and carotid endarterectomy. The 2 other high rates were total knees and bariatric surgery. And they were less interesting to us because we knew that many of the total knees were leaving the community and there would be debate over where decision-making happened. And for bariatric surgery, we no longer had a local program.
We thought it would be important to let you know who the project participants were. And the clinical lead for it was the IPA. And the IPA is a physician-owned organization, and it administers HMO products. Its formal mandate is in the administration of these products and claims management. However, it has evolved over time to drive a lot of quality improvement projects across the community, both for populations that they hold the plan for, but also across all populations. And they provide administrative and clinical leadership for these projects. The other significant player is Aligning Forces Humboldt, which is housed at the Center for Rural Policy at Humboldt State University. And Aligning Forces is one of Robert Wood Johnson's major initiatives across the United States to improve quality. And its premise is that providers, patients, and payers need to come together to derive significant change in healthcare delivery. Aligning Forces is acted as a hub for community liaison and outreach to different partners in the community, and it has been the driving force for creating ongoing patient engagement or consumer engagement, depending on the terminology and setting, projects linking and bringing patients into the heart of quality improvement work. And this focus has been going on for about 5 years, and there's been a gradually increasing skill set in how to do that effectively. There has been a long string of projects now where Aligning Forces Humboldt and the IPA have worked together, bringing the expertise in consumer engagement and clinical work into joint projects that benefit all parties, patients and providers. This particular project, meaning the Surgical Rate Project, was supported by CHCF and the Robert Wood Johnson Foundation.
So how did we get to a project? Well, high rates do not necessarily indicate that there's a problem, or perhaps the state average is not necessarily the right rate. The data was concerning for us. We also went on to look at rates in neighboring counties. We looked at the rates in academic medical centers like UCSF and Stanford. We even looked at the rates in Orange, where one of our hospital systems is centered. And in all cases, we were still an outlier. So we felt that data this compelling and potentially important to the community had to be followed up and had to be investigated. So we decided to design a project. So we started our work to design. We went out to recruit partners for the project, and we sought funding for the project. I think a key decision that we made, especially looking back, was to be very clear that this was to be a quality improvement project. We would have Baker's data, which was very good at the community level, but without detail in the rates for individual surgeons or even individual hospitals. We would not attempt to do any case review or work back and try and produce individual rates. Again, this was a QI project and not an attempt to find bad actors or institutions. And this turned out to be actually a pretty good decision, especially in recruiting clinicians and other people to participate in the project. So the project was designed around 3 tracks, one for the community group, one for PCPs, and one for surgeons and specialists. And actually the only specialists involved at this level were cardiologists in the case of CABG. Each track would generally receive the same interventions, but customized to their interest and training. So moving to the community group, these were people with community standing. We chose them to represent a constituency like employers or patients or Native Americans, and we wanted people without a connection to healthcare. which actually turned out to be pretty difficult. And of course, they had to be willing to contribute a fair amount of time. And I'm not sure, looking back, that we were completely honest about how much time. We were very lucky in the quality of the people who joined the community group. We knew that they would need time to understand the clinical and healthcare issues, and they were willing to participate in extra meetings to get up to speed. In fact, sometimes back-to-back meetings for that group. We covered a lot of material in a very short time. We had topics that we would present for about half of each meeting, and then we'd spend the rest of the time in discussion and answering questions. So, interventions. The plan was somewhat simple, or at least it seemed so at the time. We would bring Dr. Baker to the community to meet with each of the 3 tracks, and then we would follow with the 4 academic clinical specialists, each in turn. We used the same schedule for all the visits. The speakers would arrive Thursday evening and then meet with the community group for a couple hours during lunch on Friday, and then meet again with the PCPs for dinner. The following day, they would meet with the surgeons in the morning. It was a pretty intense 2 days, and I think they earned their fees. About halfway through the project, we began to realize how much effort all the logistics were causing. I felt like I was running an import-export business that did a lot of catering on the side. Not counting the extra community group meetings, there were 16 meetings to be scheduled, invite participants, hire a hall, and then try and get everybody to come. And I think that's always been the hardest part, trying to get everybody to come. We had a lot of help from our clinical champions who were IPA leadership in that part. The last intervention was an introduction to shared decision-making. We felt it was likely a partial solution to the high rates for preference-sensitive procedures, and that we would provide shared decision-making concepts and education throughout the project activities.
So we thought we'd review what the meeting agendas were, and we didn't walk into the project understanding that this is what they needed to be. As Martin mentioned, this was a quality improvement project, and as in many quality improvement projects, you know what your aim is, but how you get there isn't clear when you start, and that was absolutely the case in this example. The first couple meetings didn't have this agenda clarified, but after each one, Martin and I would debrief. We'd talk with our clinical champions and understand what seemed to go well and what seemed not to go so well. And then we were very fortunate to have a really excellent consultant come in on the topic of hysterectomy, who was willing to hear all of our input about what had and hadn't worked, and she distilled down this meeting agenda, which we then suggested to our subsequent consultants, and they found very useful. And it ran along this line, a review of the procedure and, you know, including technical drawings, what does it mean, how does it happen, indications and benefits, risks, and then new treatments that might not be well known to our community, to make sure that there wasn't technology or procedures that sort of hadn't penetrated into our consciousness. Then there would be a discussion of geographic variation, and that always engaged people. Oh, maybe we're at the state average or higher than the state average, but we might be lower than Alabama's average, or we might be way higher than Europe's average. So understanding that there's variation beyond California, but across the country and across the world for use of these procedures. And then a discussion about why a patient might prefer a particular approach, provider preference and health system bias. And these often generated very rich discussion with both the groups themselves, for instance, patients saying, well, someone might want to go ahead and have a surgery because they might not have coverage the next month, so they think they better get it done. And then also some projecting about why one of the other groups might have a preference, so that it might be driven out of economic reward, or providers might have an opinion about why patients might want to do something. At every meeting, we raised the issue of shared decision-making, and this was really an area that we acted as advocates, I would say. In the rest of the project, we attempted to be as neutral as possible, bringing data, bringing experts, and allowing the discussion to reveal what may or may not be the truth of the situation. But in shared decision-making, we raised it at every meeting, and we asked our outside consultants to raise it at every meeting. And in a later slide, we'll talk about some of the experiences and learning we had around that. It was very interesting. We found that a portion of each meeting that really engaged people, and again, this was community members, the primary care community, and the specialist, was case presentations. Here's a case, and how would you think about this, and where might a patient's preference or a provider's preference come in and influence the decision-making, but it brought it from a theoretical construct down to the sort of challenges that people face in their real practice or in their everyday life. And then the question was always raised, why are rates high? And in the first meeting or two, this generated a lot of heat and, sort of wrestling with the data, even after Dr. Baker's visit, where there was a lot of discussion of the data. In the first clinical meeting or two, there was a lot of, well, the rates are high because the data is wrong. But after a while, the viewpoint really got to that this was really an attempt to understand this and understand what the right rate is. And each of our consultants very clearly said there isn't a known right rate. And what the community has to understand is, are you applying best practice, and are patient preferences being honored? So there was a real movement away from that being a critical focus of the meeting as the project progressed. And then, even though the general overview of the topic and this discussion pattern that I talked about was applied to each group, it was adjusted according to the needs of each group. And for instance, the community group might get more sort of background information on, what's the anatomy, what do we mean by this. And for the primary care group, there might be more interest in the clinical discussion. How do I make this decision? What's the background information? And in the surgical group, there was a little different emphasis. And we'll talk more about the nature of each of the groups in our next slides. So the next one is about the highlights of the interaction with the community group. I have to say that our what turned out to be quite a successful experience with this was genuinely based on our progressive experience in bringing non-medical people into quality improvement projects. And this, as I mentioned before, has been an evolution over about 5 years. And we started with how do you engage people in their personal health, self-management, and so on, brought patients then initially into clinical microsystem work, and now at this higher, more complex level. And I think it would have been very difficult to be successful in this project if we hadn't had those prior experiences. Martin mentioned our success in recruitment and getting people that not only were of weight and represented constituencies, but were willing to devote just an astonishing amount of volunteer time to this. And we heard from them how engaging and how important they felt this work was. And then we realized that we really needed to spend the time with them to educate them and provide them with the conceptual tools to be full partners in the process. So there was actually 4 meetings, one of which was about 6 hours prior to the meeting with Dr. Baker, where we discussed what is variation, what does preference sensitive mean, what's a hospital service area, just basic foundational concepts that people who were not in the field needed to have before they could successfully interact and feel confident in interacting in the discussions. And then Dr. Baker's visit was extremely successful. He has a great ability to talk about complex statistical concepts in a way that people can grasp. Our community group had formulated some questions about data that they had. They really had sort of the same reaction to data that so many people do, that it's wrong. How could this be true? And he was really able to address them. He took the questions they had, and if he didn't have an answer readily at hand, he did research and responded back to them. So it really validated to the group that they were able to grasp this information, that their questions were legitimate, and that they were able to think of questions and nuances that the expert hadn't. So it increased their sense of competency. And then each of the physician visits, which each of them had a slightly different flavor to them, but they were able to engage with the information, and they found it really fascinating, both the kind of technical concepts and learning about how do providers think about things, what are the range of decisions that go into the provider's point of view, and then talking about, well, how do we think patients think about this? And so they were very, very successful at this. And by sort of luck of the draw, for our first clinical specialty, the physician was not able to make it in time. We were fogged out for the community group meeting, so we had asked one of our local primary care physicians to come in and do the presentation, and he talked about the subject in a way a really excellent primary care provider would. Here's what it looks like, and here's how I think about it, and here are the choices. And that was a really great sort of transitional step into having a specialist talk about things, and it turned out to be a very successful visit. There was also the function where Martin and I attended both the primary care meetings and the specialty meeting, and we served sort of as messengers back to the community group, saying this is what we observed in these meetings, these were the issues that were raised. So the community group sort of kept getting feedback of what was going on in the medical community, but the processes were really they were completely parallel, without interaction except by report until the very end. And we think that this was successful. It allowed each group to have time to process their thoughts and experiences in regards to the topic. The community group, they didn't really know what they were doing, and we weren't entirely sure. What was their mission? We just wanted them to learn about it, and it became clearer over time, and they became more confident in their ability to weigh into a very complex medical issue. In the beginning, I think we got sort of a fairly typical yo-yo between I can't possibly reflect on what a physician is doing and where's the bad actor. You know, if we have a problem, there's someone that's doing the problem wrong. And as they evolved and understood the system issues, they were able to weigh in a very sophisticated way. The next track was the primary care track. I have to confess that when we initially conceived of the project, we thought of specialists and community, and we didn't think of primary care until about 10 minutes later, which was very fortunate that we got smart, because this was absolutely essential, and if we hadn't gotten there, it would have been not a good project. The primary care community really were interested in, how do I take care of these problems? They wanted nuts and bolts. They wanted clinical guidelines. They wanted, if I have someone with abdominal pain that goes on, and maybe it sounds a little bit like the gallbladder, but I'm not really sure, I want help on how to decide how to manage this person. And when I send them to the surgeon, I'm often asking for a second opinion. There were some primary care members who said, I'm asking for surgery, but many of the primary care community said, I want help with complex decision-making in ambiguous cases. And that's what they wanted from the specialist. They weren't so much interested in sort of theoretical models and why is there variation and that sort of thing. And actually we found that the clinical experts were somewhat hesitant to play that expert role of the group. They didn't say these are the standards of care, and in some cases perhaps that's not so clear what the standards of care, but even when issues emerged that seem to be quite marked variation from what might be considered normative standards for care for a clinical problem, the clinical expert was quite reluctant to say, other people in other communities aren't really doing that. So that was an interesting observation we had. Within the primary care group, there was a lot of open communication. People wanted to be able to say, well, what do you do? And hear what their colleagues did. And there was a reflection amongst the group that a lot of that had gone on before in the context of meeting in the hospital, but now that many people don't follow their patients in the hospital anymore, the ability to have sort of curbside consults, both with specialists and amongst themselves, had really been lost, and that this was a great miss for them and left them feeling adrift and insecure with making decisions. And again, they noticed that maybe they thought maybe surgeons didn't really understand what the primary care community was asking for in a referral, and sometimes that the communication around that wasn't clear or easy, and that perhaps this has been exacerbated by click and refer kind of setups rather than the old-fashioned consultation request letter.
So talking about the highlights of the surgeon meetings, I think for both Betsy and myself, in many ways, the surgeon-to-surgeon meetings were the most interesting. Surgical experts and the local surgeons were at the same clinical level, that they really shared the same technical education, and they were both interested in making points to each other. We were actually initially concerned that these would be kind of contentious meetings, and I think that there was some worry among the surgeons as we tried to recruit them to the meetings, that would be true. However, they turned out actually to be pretty friendly, and often the surgeons shared acquaintances or have been to same schools, or they in some way knew the same people. And all of our clinical experts really made an effort to establish a connection sort of before the meetings really got going, and that turned out to be pretty useful. In fact, some of our experts seemed to identify more with the surgeons in the room than they did with us. Referrals also were in the background. We recruited our experts from UCSF and Stanford. Those are tertiary referral hospitals for people in Humboldt. So I think it was an interest for everybody to get along. Nevertheless, these very small sessions really had frank and I think useful conversations. Those efforts to connect people at the beginning of the meetings really resulted in very honest discussions and sometimes surprising discussions. And as Betsy just described, there really were different expectations between the surgeons and the PCPs about what was expected from a surgical referral. Do PCPs expect surgeons to consult on their patients and return them for decision-making, or do they expect surgeons to just go ahead with the surgery? And I was surprised to hear a couple surgeons say that they considered not doing surgery, but they worried that if they didn't do surgery when a patient was referred to them, would they continue getting referrals from those PCPs? And I think this is probably one of the more useful findings from this project. I think this is something that we can work on in this community, and I think from both sides that there's a lot of opportunity here. We felt at the end of each of these surgical meetings that we actually had a pretty good idea of why rates in Humboldt might be high. And as I think we expected, it reflected some aspect of local surgical decision-making that was generally considered an acceptable local norm in Humboldt County. So moving to finding and working with the clinical experts, this was really one of the harder parts of the project. It's really not a role that many people put in their CV. We worked with Pacific Business Group on Health, who really has a lot of connections, and they were able to find us a small number of candidates, but it wasn't necessarily an attractive job for everybody we talked with. And I think we spent about 2 months trying to find our 4 experts. The profile of those I think that actually did come up to Humboldt were people associated with a teaching hospital, and they had a special interest in the procedure that we were investigating, even before we asked them to do this work. As Betsy said, the meetings didn't go exactly, I think, as we thought they would in terms of the clinical experts presenting best practices and how it worked at the academic medical centers. The experts didn't seem very comfortable proceeding in that way. And so they preferred to lead the discussion about the procedure or really talk about how things worked in Humboldt County. And there really wasn't a critical word. As Betsy's also pointed out, we really didn't know how this was going to work when we started out. We had some ideas about agendas. We certainly tried to pass those on to our clinical experts, but it really got a lot better from the beginning until the end. We were able to, I think, at the end, tell people what we expected them to cover and what would work and what might not work with each of the groups. Interestingly, I think speaking to the community group was something that the experts found challenging, and we got a lot of questions there, and they seemed concerned that they wouldn't hit the appropriate technical level. But to our eyes, it worked very well, and I think I heard from all of those clinical experts that they really enjoyed meeting and talking with the community members. Since this was new material for them and for us, it became clear that it was important to keep talking with the experts. This happened over about 4 months, and so we had to keep checking in with our experts and talking about the details and how the meetings would process. But we learned a lot from this back and forth discussion for ourselves. Disappointingly, we didn't find any of the clinical experts were very expertise and in shared decision-making. In fact, I don't think any of them had any formal experience with shared decision-making. And I think a couple even had some difficulty in supporting the concept during the meetings and their visit.
Betsy and Martin, this is Giovanna. I just want to let you know we have about 15 minutes left on the call, so we probably should try and wrap up the formal presentation in about 5 minutes to allow for any questions.
Okay. Well, it's such a great project with so much that we learned. It's hard to do that, but I will step up to the plate and speed along here. So our next topic is shared decision-making. As Martin mentioned, it seemed to have very little background knowledge in our clinical experts and also in our community. And in general, people seem to think that they were doing it and doing it well, but it was with pulling the layers off, what they were doing was the usual risks and benefits of a procedure. We kept raising the issue at every meeting, and with our community group, we actually pulled out some tools, had them work with it, and they developed a lot of interest in the subject. The primary care providers were more receptive to the concept than the specialists, but they had the usual concerns around, you know, how am I going to cram this into my already busy schedule?
So that takes us to the final meeting, which really went very well. We had representatives from all the tracks and specialties. Most of the community group was there, and CCRP moderated and explained their role in connecting the community to research about the community. So after the introductions, one of the community group members sort of got us off to a really good start by recounting his and the group's journey to get to this meeting, how they developed their recommendations. He talked about how he felt about the data and the clinical information he received from the experts, and how it affected him as a representative of the community. It was really very compelling, and I think it really set the right tone. It communicated how much effort the community group had put into the project and how they'd become personally involved. We went on to read the recommendations. They were well received. Everyone in the room was asked to react. We heard a lot of things during that reaction part about how the system was biased towards surgery. There was some interest in shared decision-making, and we actually had some offers of help with implementing the recommendations in the community. I think the clinicians were genuinely impressed by the community group, not just the recommendations, but how they reacted during the meeting, their comments, and their comfort in participating in the discussion. Several clinicians acknowledged the worth of having the community group involved in how care was delivered. That was, I think, a new thought. And I think for both Betsy and myself, the high point was when several physicians suggested that the community group should participate in the ongoing discussions at one of the hospitals about what services and products should be available at that institution. That was very rewarding.
So our final slide is to offer you the actual recommendations from the community group that they developed really independently themselves, and then take your questions. And the first and strongest recommendation was that there really needed to be a shared decision-making program in the community, that the community members, saw this as the way to address variation and to honor patient preferences. They saw the need for improved communication between primary care and specialty care, and that there should be some formalized methods so that everyone, including the patient, could be on the same page about what the purpose of a referral would be. They recommend standardized evaluation and treatment guidelines, protocols, though they didn't use that terminology, for common conditions. They found it really quite shocking that different providers did really markedly different things for the same condition. And they recommended that, and this was their term, that the medical community accept community-wide data and that should continue to be monitored and move towards individual physician, surgeon data being available for public consumption. And finally, that the community group continue to be involved with understanding and weighing in on community-wide healthcare issues. So we thank you, and I think we're ready to take any questions.
Great, thank you so much. So for folks on the phone, please feel free to chat your questions, or you can also raise your hand if you prefer to ask your question verbally. I do have two questions lined up. The first was, you kind of talked about this already, but to what extent do you think the community group kind of understood the shared decision-making techniques, wanted to be involved as consumers in shared decision-making conversations? And I know this was a recommendation, but what do you think are the next steps in terms of rolling that out? Have you given that any thought?
I will answer the first part, and Martin can answer the implementation part. They really had no idea when we started the project and about what shared decision really means. But we, as I said, we opened up, we got access to some of the really high-quality products, walked through them with them, discussed how it might have changed some personal decisions in themselves or their family members had they had access to the information. And at the end, they just were 100% that this was really a necessity to deal appropriately with preference-sensitive procedures, that it really should be based on the patient preference. Implementation, Martin?
So for those of you who get health affairs, one of the recent issues talked a lot about trying to implement shared decision-making in a number of different settings. And the take-home from that is that it's fairly difficult. We're definitely interested in doing this. We have some resources here at the IPA around our care coordination project and people within that who probably have the right skill set. So we're trying to, our vision is that this is probably a lot about logistics and making it an easy referral for a primary care physician. And I think that, you know, the big questions are how to pay for it and how to get clinicians to use it.
Mm-hmm. Great, thank you. Another question, was there, you know, we know that you started off with these higher rates than the state average of the elective surgery rates. When you went through this process, was there discussion or evaluation about complication rates? And any
No, we didn't have any data on complication rates. It is something that came up during the discussions about collecting data going forward. And as you might imagine, there's strong feelings on both sides about, you know, obviously complications are important. It's also hard, since many complications are late, to accurately tally them.
Great. And then there was a question about the variation in surgery rates among individual physicians.
So we didn't have any data about individual surgeons. All we had were rates at the hospital service area level.
Mm-hmm. Was there interest in that type of data among the groups?
Well, certainly there was with respect to the community group. They're very interested in that data, and I think one of the things they'd like to see going forward is that we're able to develop that data. I think that it was sort of a sensitive subject for the surgeons, and I don't remember it really coming up as an issue for the PCPs.
Interesting. Have you seen any changes in community practices yet? It sounds like there's been a tremendous culture shift.
You know, there's speculation that there is change in community practice. I don't think we'll know until we start counting.
Yeah. And then one more question.
The culture shift was profound. But go ahead, sorry.
Yeah, no, go ahead. Do you want to continue?
Having done the patient or consumer engagement work for quite a long time, having patients sitting as complete peers, as a matter of fact, weighing in with recommendations on how medical providers or medical systems should react, and having that embraced and accepted was a marvelous moment, and gives me great hope, actually.
Yeah, I certainly echo what Betsy said.
It's really exciting to start having these conversations. Were there chart reviews involved to determine whether and why the number of surgeries was high, and if so, then typically how many charts were reviewed?
No, this was a looking forward project, so we did not go back into charts. In fact,
you kind of said that at the beginning, that your frame was really a QI project looking forward, right?
Exactly.
Yeah. And then could you remind us of the timeline of the project? So you initially, the All Over the Map data came out in 2012 or 2011?
2011, in the fall of 2011, and we talked about it throughout the fall. I think that you know, it was challenging to figure out exactly what to do about it, and so it sort of took us to the beginning of winter, I guess, to start to figure it out, and then it took 3 or 4 months to put it together. So we really started in June of 2012. And we've just finished up.
Yeah. And then there's a question about how you're communicating to the PCPs and the specialists beyond those who participated in the group, in the tracks.
Yeah, well, I think that we're really starting our community-wide communication right now. So we've got the recommendations, description of the project, who the community group is, and we're approaching a lot of different people with that. The hospitals, the hospital boards. We'll probably end up with something in the local newspapers. It will be part of the IPA's communication to its members. I think that this communication part is really just starting to play out.
We had just in the past week or so, a follow-up meeting with the community group where we talked about a couple of things, and one of them is who did they think it was important to receive communication around it, and they mentioned providers. They actually wanted a letter into every provider, but we talked about perhaps there being more effective ways to get the information to providers, and then to community members, the board of supervisors, and so on. And the other thing was that the community group as a whole 100% committed to ongoing participation and interest. Again, exactly what form and mission is now unclear again, but they are willing to continue to serve in this capacity on a going forward basis.
Great, and then one final question before we wrap things up, and you started to talk about this a little bit, but to what degree do you need local physician leadership, or can this be community-based without those physician leaders?
Oh, I really don't think that this would have worked without those local physician leaders, and we were very lucky to find leaders who really have a lot of standing in the community, have been recently chief of staff at the hospital and who are part of the leadership of the IPA. And they were very important in figuring out how to approach clinicians and helping us get clinicians to come to the meetings. I think we were probably meeting every couple of weeks over this project for the last 6 or 7 months. So they're key. I don't think you could do a project with this without that kind of leadership.
Yeah, as we find in so many projects like this, we really need that physician champion involved. Great. So just before folks start hanging up, there's an exit poll on the right-hand side. You might need to expand it if all you see is the chat function. If you could just answer the exit poll, that gives us some quick feedback about how the conversation went today. And Martin, if you could pass the ball back to me, I just want to finish one final slide, and thanks for attending. Great. Great. So I think for folks who called in before I said this, we do post the webinar recording and the slides on our website within about a week of this phone call. So if you registered for the call, which I assume you did since you're on it today, then you'll receive that. And then I also mentioned at the beginning of the call that we'll also include a link to the newly released all over the map data as of yesterday, and to a wonderful interactive article or story, if you will, about the Humboldt experience. And so I'll include links to both of those publications when we send the email out. Thanks to Martin and Betsy for joining us today and sharing your work, and really impressive, innovative ways to look at this from a community perspective. So congratulations on all of your hard work. Thanks to everyone who joined, and please finish the poll or complete the poll before you hang up. Have a great day.